All right, in this explainer, we are going to build a solid clinical framework for a disease you are absolutely guaranteed to see, either in your day-to-day practice or for sure on your exams. We're talking about chronic lymphocytic leukemia, or CLL. We're going to go step by step from that very first blood test all the way to the most critical, life-threatening complications. So, let's get right into it. But before we really dive in, I want to give a quick but very important shout-out. The framework for this whole explainer comes from the excellent educational materials put together by Dr. Mohammed El-Menaghi Mohammed. His work is what provides the clear, solid foundation for our review today.
So here's our game plan. First, we'll nail down the basic definition of CLL. Then, we'll look at how patients actually show up in the clinic. After that, we'll walk through the entire diagnostic workup, cover the key complications you need to be watching for, and then we're going to zoom in on a really critical event called Richter's transformation.
Okay, so first things first. What exactly is CLL? Well, to put it simply, it's the single most common leukemia in adults in the Western world. And, that fact alone makes it an absolute must-know for any clinician.
So at its very core, CLL is a cancer of the blood and the bone marrow. It's defined by this out-of-control growth. We call it a monoclonal proliferation of a very, very specific type of white blood cell, a mature-looking lymphocyte.
And here is a massive detail. What kind of cell are we talking about? In a staggering 99% of cases, the rogue cells are B cells. Now, this isn't just a fun fact. It's the fundamental piece of the puzzle that our entire diagnostic strategy is built around.
Okay, so how does this disease actually pop up in the clinic, What's that very first clue that tells you a patient might have CLL?
Just take a second to think about it. The word leukemia sounds pretty dramatic, right? You might be expecting a really obvious, severe presentation. But what does that typical patient story actually look like?
And here it is, the classic exam question and the real-world truth. Most patients have zero symptoms, none. The diagnosis is very often a complete surprise, something that gets picked up on a routine full blood count that just happens to show a really high lymphocyte count. Now, of course, when patients do have symptoms, it's a bit more of a familiar picture. They might come in with those classic constitutional symptoms like weight loss, or maybe issues that stem from a messed up immune system like getting infections over and over again, bleeding because their platelets are low, or having swollen lymph nodes.
Now, this right here is a fantastic clinical pearl, especially for your physical exam. When you're trying to tell the difference between CLL and chronic myeloid leukemia, or CML, just remember this. The lymphadenopathy, those swollen lymph nodes, is typically way more significant in CLL.
Okay, so we've got a clinical suspicion. Maybe it's that incidental finding of a high lymphocyte count. How do we go from, this is weird, to, okay, this is CLL. Let's walk through the diagnostic workup.
It's really a pretty logical three-step process. We kick things off with the basic, full blood count. Then we take a closer look with a blood film. And finally, we seal the deal with a very specific test called immunophenotype.
That full blood count really tells the story. So lymphocytosis, that high lymphocyte count, that's the hallmark. But you can't stop there. You've also got to look for low red cells, or anemia, and low platelets, which is thrombocytopenia. The really crucial thing is to understand why they're low. Is it because the bone marrow is just getting crowded out by all those leukemia cells? Or is it something else, like an autoimmune attack, which is a really common complication here?
So next, we look at the blood film. And this is where we find one of the most classic, pathonomic signs in all of hematology, smudge cells. Now, these aren't some weird, different type of cell. They're actually just the fragile leukemic B cells that literally get crushed and smeared while the lab tech is preparing the slide. So seeing these is a huge clue for CLL.
But look, while the FBC and the blood film give us some really strong hints, the gold standard, the test that gives us the final, definitive answer, is immunophenotyping. This is what's going to confirm the true identity of those lymphocytes.
So what this test does is look for specific protein markers right on the cell's surface. We're expecting to see B cell markers, of course, like CD19 and CD20. But the real kicker for CLL is that these cells also express CD5, which is a marker you usually find on T cells. This weird combination of CD5, CD19, CD20, and CD23, that's the unique signature that locks in the diagnosis of CLL.
So we've nailed the diagnosis, but CLL is a chronic disease, right? A lot of the management is really about watching for and treating the complications that pop up over time. So what are the big ones we need to have on our radar?
We can kind of group the major complications into four main buckets. First, you have bone marrow failure, which leads to things like anemia. Second, there's immune dysfunction, or hypogammaglobulinemia, and that's what causes all those recurrent infections. Third, you can get an autoimmune attack on red blood cells called warm AIHA. And finally, the one everyone dreads, the transformation into an aggressive lymphoma known as Richter's transformation.
And just to show you how common some of these can be, just look at warm autoimmune hemolytic anemia. Somewhere between 10 and 15% of all patients with CLL will end up developing this condition. That's where their own immune system literally starts destroying their red blood cells. It's a really significant cause of problems for these patients.
Okay, for our final section, let's really focus in on that most serious complication. Because honestly, being able to recognize it can be life-saving. We are talking about Richter's transformation, and it represents a sudden, dramatic turn for the worse in a patient's condition.
So what is it exactly? Well, Richter's is when those slow-growing chronic leukemia cells basically change their whole personality. They transform into a really aggressive, high-grade lymphoma, most often a diffuse large B-cell lymphoma. The disease goes from being a chronic, manageable issue to an acutely life-threatening emergency. And the way this shows up in the clinic is usually sudden and severe. The red flags you absolutely have to look for are things like a single lymph node that is rapidly getting bigger and is often painful, high fevers without any obvious infection to explain them, and those classic B symptoms like drenching night sweats and major weight loss. Any one of these demands an immediate investigation. And that brings us to our final and most critical takeaway. If you have a patient with CLL, one who has been stable for years, and then all of a sudden they become acutely unwell with the kinds of symptoms we just described, there is one diagnosis you absolutely must have at the very top of your list. You always have to consider Richter's transformation. Thanks for joining me.